I think we might get started, and for those of you that are joining late, we're happy to fill you in. This is meant to be somewhat of an interactive session where feel free to ask questions in the middle, we're happy to answer them as we go along. And so this is a good opportunity for us to introduce our Yale team here. Some of the topics we talk about are specific to Yale, but we've kind of tried to make it a little bit more broad-based so that those of you that are being treated at other places will also have hopefully enough similarities to think about. And so I think without much ado, I think we're going to get to our first speaker. Our first speaker for this afternoon is Terri DiClementi. So Terri is one of our physician's assistants, has been in surgical oncology for over a decade. And Terri is very experienced with thinking about cancer patients, and will speak somewhat about what should you do when you have a cancer diagnosis if you're a patient, caregiver, and how can you kind of advocate for yourself. So with that, Terri.
Good afternoon. Good afternoon, everyone. Thank you for joining our Yale breakout group. My name is Terri DiClementi, and I am a surgical oncology PA here at Yale. Today, I will be discussing navigating a cancer diagnosis, what to do after hearing the words, "You have cancer." We will break this down into 4 parts. First, take time to absorb your diagnosis, then establish your support team, educate yourself, and choose your medical team. Take time to absorb your diagnosis. After receiving a cancer diagnosis, it's normal to feel many different emotions. We see patients who become angry, feel sad, frustrated, and even confused, while others are instantly positive, saying, "I'm going to beat this." All of these are completely valid feelings. Take a pause and know that you're not alone, and let yourself feel and work through all the different emotions. Everyone's emotional path is different. Focus on yourself and your goals. Try not to let the cancer diagnosis consume your day. Continue to surround yourself with people and things you enjoy. Establish your support team. Surround yourself with friends and family who are positive and supportive. Always start with you. I would encourage you to make a list of what's important to you. I often see patients making decisions based on what's important for their loved ones. For example, a patient may feel very comfortable with their current doctor, but a family member is pushing them to get a second opinion. Or a patient may feel overwhelmed and want to hold off on an appointment, while a family member wants them to be seen as soon as possible. At the end of the day, this is your health and your journey. Have open communication with your support team so everyone knows your goals and wishes. We always encourage patients to bring a family member or a support team with them to their appointments. Appointments easily become overwhelming, especially at the initial phases of a diagnosis. Your support team can be by your side, taking notes and helping to remind you of questions or concerns you may have wanted to discuss with your doctor. Educate yourself so you can advocate for yourself. It is so important to be educated on your disease, especially when you have a rare disease like appendix cancer. You can find education by joining support-centered groups like ACPMP and support groups where you can learn from patients who have had similar experiences. Remember, appendix cancer is very rare and unfortunately poorly understood by many community physicians, with education comes knowledge and a better understanding of your disease and your treatment options. Choose your medical team. Be an active member of your care team. You are the center and the most important person in the team. It's okay to seek second opinions. You need to feel comfortable with your medical team and confident that they are providing you with excellent care. A common misconception is that we will be offended by a patient seeking a second opinion. But I think the reality is whatever you need to do as a patient or a family to feel confident in your decision is absolutely what you should pursue. Again, make a list of what's important for you and have open communication of your wants and needs with your medical team. Are you the type of patient who wants everything done to try to cure their cancer? Or would you rather your surgeon leave some cancer behind if it means needing to give you an ostomy bag? This is so important to find a team of medical providers who specialize in this disease, who are up to date on research and who are pioneering efforts to improve treatment and cure rates. I believe our team here at Yale is doing just that. When you present for your first doctor's appointment, it's important that you bring all your medical information. Your doctor will review all relevant information to develop a care plan. This includes operative reports, pathology, and imaging. If you come to Yale, our team will request all physical images, pathology slides to be reviewed by our appendix cancer experts. We will confirm that we have the correct diagnosis and then formulate the best treatment plan for you. If you have genetic testing done, such as Foundation 1, Caris, or Tempus, please bring these results with you. We will likely order ctDNA testing to monitor for disease progression or recurrence, and germline testing to look for familial mutations that may have led to your cancer. Again, remember that appendix cancer is extremely rare. ACPMP reports that recent research has found that worldwide rates of being diagnosed with appendix cancer is only about 10 in 1 million, and PMP is only about 3.2 in 1 million. This means that many physicians may have never had a patient with appendix cancer or PMP. Dr. Turaga always says, "I come to work every day with a goal to cure cancer," and he has a team of physicians and researchers with the same goal. Our peritoneal surface malignancy team here at Yale is composed of a medical team and a research team. Our medical team of surgeons, oncologists, pathologists, physician assistants, nurses, dietitians, and physical therapists work together as a multidisciplinary team to treat our patients. We're focused not only on getting you through your diagnosis and treatment, but also on your survivorship journey. We provide patients with support groups, sexual health and fertility counseling, psychosocial and social work support, as well as palliative care referrals. Our research team collaborates with more than 200 attending physicians, more than 50 surgical trainees from around the country. They're currently working on establishing medical education and standardizing the treatment approach to appendix cancer and PMP. Because this disease is so rare, it's very much underrepresented in medical research and education. The National Comprehensive Cancer Network, or NCCN, establishes guidelines that are used by medical and surgical oncologists as a guide to care for their patients based on the most up-to-date research. However, they still don't have guidelines that are specific to appendix cancer. Therefore, it is so important for research groups like these who are dedicated to doing better for our ACPMP patients. The next couple of slides are of the current Chicago consensus guidelines. These are the pathways that our research team is working on updating based on research gathered over the past 5 years. We use these pathways as a standard of care for our patients. They're broken down by specific disease and help guide patient care from the time of diagnosis through treatment and surveillance. There are, of course, differences in the pathways based on the disease, but the premise of each is the same. After confirming the correct diagnosis, the pathway will guide treatment options, whether that be surgery or chemotherapy, and finally recommendations for surveillance after treatment. This first is of the appendix cancer pathway, we then have the Lamin pathway, and finally the goblet cell adenocarcinoma pathway. If you'd like a closer look at these, you can search the Chicago Consensus Guidelines. And with that, I'd just like to say thank you for joining, and remember to stay positive.
Wonderful. Thank you so much, Terri. I think, there are some key messages that I think many of you might have heard even in the morning session. First of all, you and your family are your best advocates for this disease. And I think, make sure there's someone else with you as you're kind of going through this journey, someone who's able to kind of listen and take notes. And I think, remember, we are here to support you. We're here to understand what you're going through and try to help you through this. But I think the more you are knowledgeable of your disease, the more you keep a file or folder with everything that's been going on with you, I think the better questions you'll be able to ask and the better you'll be able to advocate for yourself. So thanks, Terri. I think we'll, leave time for some Q&A in between some of our sessions. But our next speaker is Evelyn. Is Evelyn speaking next? Yeah. So is Evelyn Afriyie, who is one of our nurse navigators who is going to be speaking about navigating a new patient process and what do you need to think about.
Good afternoon, and thank you for joining us. I will be talking you through the pre-visit, visit, and follow-up process at Yale New Haven Hospital. A referral to a complex surgical oncologist can be a stressful phase for a patient's cancer treatment journey. It has different meanings depending on the stage of their cancer treatment plan. At Yale New Haven Smiler Cancer Center, we receive referrals. We receive referrals throughout the country and all over the world. Our referrals are sent via calls, email, and electronic. We have process for our out-of-state and international patients as well. For our out-of-state patients, we use a tool called Pinnacle. Pinnacle Care allows patients to receive a virtual second opinion without traveling in person to see a doctor. If this option is chosen, a member from the Pinnacle team will contact the patient directly and get more information and medical records. Once the records are obtained, Pinnacle will create a platform to upload all the necessary medical records. The physician then reviews the record and generates a report that will be shared with the patient. For our international patients, we have a dedicated team of international patient navigators that can assist patients and providers with the referral process. Information that we need for a referral. First of all, we need your demographic and insurance information. We need your oncology progress note, current and prior chemo regimen, your most recent colonoscopy report and images, any surgical report that would be helpful. We ask for genetic testing, such as FoundationOne, germline, and ctDNA if available. We also look for tumor markers, the CEA, CA125, CA19-9, and CRP. Images of CAT scan, chest, abdomen, and pelvis, MRI or PET scan are always very helpful. We use electronic records to obtain all your medical information prior to your clinic visit. We also use FedEx to obtain images if your facility doesn't have Epic or PowerShare. Our goal is to see our patients within 7 days of referral. We do see patients from various stages of their cancer treatment. We see newly diagnosed cancer patients such as appendix cancer or peritoneal cancer. We also see patients that are coming in as part of their treatment plans. Second opinion patients and patients who also come in as self-referrals. Diversity. We encounter patients from diverse social economic backgrounds, and therefore we are mindful of their health, financial, emotional, and social well-being. Our goal is to provide a tailored care to meet patients wherever they are in their cancer care journey. For your clinic visit, I call patients prior to their clinic visit to establish rapport. This helps set expectation and alleviate some of the anxiety that is associated with seeing a physician. It also creates an opportunity to assess the patient's knowledge of their disease. It allows us to assess any barriers to successful treatment outcome. We discuss flow of our clinic and the approximate length of visit. I also encourage patients to bring a family member to advocate and support them during the visit, and also bring a notepad so that they can take notes and ask questions. Our multidisciplinary team include a surgeon, Dr. Turaga, a surgical resident, APP, nutritionist, a physical therapist, a nurse coordinator, and a practice nurse. We also have a spiritual and a social worker available as needed. I encourage my patients to sign into my chart so that they can continue to communicate with us and also stay abreast with their treatment plan. I introduce them to a well-list tool And this is accessed through MyChart. The tool provides a personalized resource for patients and their families. They have over 20 categories of plans, such as transportation, fitness and nutrition assistance, errands and tax support, home cleaning, childcare and senior care, financial assistance, and emotional support. They also support over 200 languages. We try to make sure that patients are able to make it to their appointments without any barriers. I provide transportation and accommodation resources to our out-of-state patients as needed. The clinic visit. During the clinic visit, you meet the treatment team with Dr. Turaga and the medical team. You also spend time with a physical therapist and the nutritionist. I take this time to also review the new patient package with the patient. The package includes a brochure on Yale's myelosurgery. We discuss advanced directives, a spokesperson form, nutrition, and CRS HIPEC information. We review any follow-up plan of care. I answer any questions and schedule the next visit and images as needed. For the follow-up, we continue to communicate with patients through MyChart and answer any questions about the visit or treatment plan. If surgery is recommended, we call patients to discuss any surgical planning process. In the next screen, I have useful information on referral to our Yale New Haven CRS HIPEC program. Thank you so much for coming, and remember, each day is a gift. Thank you.
Thanks, Evelyn. I think, one of the things that as patients and caregivers we forget is, I think patients get really consumed with, thinking about the cancer and the treatment, but there are a lot of resources at most NCI designated cancer centers like ours. So wherever you're getting treated, I'm sure there's a group of resources, and sometimes you have to ask for it, which I think is not natural. It's not top of mind, and you're always thinking just about, how do I get through surgery? How do I get through chemotherapy? But I think what Evelyn tries to do with all the patients is to kind of remind them to kind of slow down, think a little bit more holistically about who's going to manage the kids, how are you going to talk to your kids, and similarly, how do you think about other life effects? And so to speak about one of such life effects is Dana Robinson, who's our clinical practice nurse, who's going to talk a little bit about managing sexual health after a cancer diagnosis.
Hi, everyone. Thank you for having us. We'd love for you to come to Yale, maybe try a hot Connecticut lobster roll, check out our team, and we want to let you know we're super cool. We can talk to you about anything, and we're really down to earth. So we're going to move on with this topic. So managing sexual health after a cancer diagnosis. Studies have shown that sexual health and sex are just as important to people who have cancer than people that don't. We want to let you know we treat and manage all aspects of the person, including sexual health. After your diagnosis, sexual health may not be a prime focus for you, and that's fine. That's totally okay. We're here to help you navigate when the time is right for you or at any point in your journey. When you come in, we will have preoperative discussions about possible sexual dysfunction after surgery for men and women, what that's going to look like, what that could feel like. And we'll also have preoperative discussions and education about fertility preservation for men and women. And at Yale, we do have REI, which is reproductive endocrinology and infertility, and we could give a referral to that if you come to us. When you come in and you meet us, you'll realize we have a multidisciplinary approach. And as everyone has said, you'll meet many different people on our team. And we get to know you. You may form a rapport with us. You might form a relationship with us. We talk to you throughout your whole course of action. And you know that we encourage you to bring a support person or caregiver with you so you have a second set of ears. However, we understand that this is a sensitive topic, and you may not want that caregiver or support person to be in when we're talking about sexual health, which is fine. Or if they're your partner, and you do want them to be part of this conversation. So we offer private consultations with any of our team members that you feel comfortable with talking about sexual health. If it's not a problem for you, we could share ideas and thoughts as a group. We can meet one-on-one on your appointment. If that's not right for you, we offer phone conversations. And if you just don't feel like talking about it, you can always email us or shoot us a MyChart message, and we could take it from there. There's no need to feel uncomfortable about saying things. So that's a nice thing that we have here and that we could share with you however you feel comfortable. We also offer prescription medications for your sexual health and intimacy. We will bring this up to you throughout your treatment course, but you could bring it up to us at any time as well, and we could get you the medications you need for your sexual health. Another exciting thing about Yale is we have excellent referrals and connections with specialists and experts in all areas that incorporate with sexual health, including behavioral health, sex therapy, couples therapy, and support groups. And specifically for women at Yale, we have sexual intimacy and menopause program, SIMS, for cancer survivors. And for men, we have Yale Medicine Urology. And they could get you to any level that you want to be to restore intimacy or talk about fertility in any aspect or any portion of your treatment and your course with us. Our team goal is to get you where you want to be with your sexual health after your diagnosis and in your survivorship journey. And we just want to share with you the importance of sexual health, sex, and intimacy, and let you know that we have your back and we will be happy to discuss anything at all with you at any time during your journey. Thank you so much.
Thanks, Dana. I'm sure all of you that are on the call, either have yourself been affected with the disease or a loved one or your caregiver for someone. And I think it's, this is another one of those topics that sometimes kind of gets sort of, either shoved under the carpet or by the wayside where, people say, oh yeah, I got to really just think about my cancer and get through it. And what I've noticed over many years of doing this, and I think this is also proven in research, is that couples or partners actually become more distant after cancer treatment. So the remarkable part is that we have patients that are cancer-free and are doing well, and then they get divorced afterwards. So it is a very dramatic sort of an event. And I think maintaining partner intimacy, understanding yourself, how you have changed with treatment, understanding your partner, and then leveraging your team to make sure that you bring these issues up, talk about it. You could do it in support groups, you could do it with us. And so we're here to help you, but I would say, strongly advocate for that for yourself, because it is a component of your life that, even if you're not missing it right now, it could be important from a relationship standpoint. So I think after that, you're going to hear from Lora Silver. Lora is one of our dietitians who is an expert in thinking about eating well through cancer and guides patients in their journey as they're preparing for cytoreductive surgery and then even long-term in survivorship. So Lora.
Thank you. Hi, everybody. So where I want to start today is to really acknowledge that our relationship to eating and to food these days has become very complex and very complicated. We get messages from all kinds of people, all kinds of sources about what we should be eating and what diet we should be following. And eating plays such an important role in our cultures and our religions. We often have many traditions and rituals around food and eating, and we eat for so many different reasons. So food can be such a beautiful and also complicated and complex part of our lives. And we know that after a diagnosis of cancer, we know from research that vast majority of patients make at least one significant change to their diet. So it's a big topic. A really natural question that I get often, of course, is, which is the best diet for me? So which is the best diet for my diagnosis, for my surgery coming up, for my treatment? And like I said, as we know from research, most folks will make at least one major change when it comes to their diet, regarding a cancer diagnosis or after a cancer diagnosis. And this can be a really positive step and a really positive thing for folks. But again, because of our really often complex relationship with food, we do have to be careful that we don't overdo it and over-restrict. Many of us may have a history of being somewhere along that spectrum of disordered eating, for example, or a disordered pattern of eating or history with food. And then that puts us at especially greater risk for overdoing it and over dieting or over restricting. And so the best answer I can give you, since I don't know all of you individually yet, the best answer I can give you when it comes to which diet is the best for me, when it comes to having a diagnosis like this, is really to keep to keep the food as simple as possible. So when you're looking down at your plate, the fewer steps that it took for the food, whether it came from an animal or a plant, the fewer steps that food had to take to be processed and to arrive to your plate, the better. The more plant foods that you can be incorporating on a daily basis, as often as they agree with you and as much as you can tolerate them, the more plant foods, the better. And when I say that, I'm really thinking of the herbs, spices, fruits, vegetables, grains and cereals, especially whole grains, beans and legumes, nuts and seeds. I think I got all of them. Those plant foods can be so powerful and beneficial for our health, especially when we're going through a diagnosis or after a major surgery. And then also getting enough protein. We usually don't get enough protein when we're navigating particular side effects or symptoms or recovering from a big surgery. And so the emphasis on protein is really important. And a lot of what I'm doing with folks is often helping them to adjust their mindset and really adapting a mindset where they can be fueling for their health and really eating for their health and anticipating the major stressors that a cancer diagnosis and that various treatments can really represent. So with all of that said, I do still want to give you a couple very specific tips for particular moments or times in your treatment. So one is that if you're currently experiencing digestive upset, digestive symptoms, and you're really trying to pinpoint or understand, why they're happening and when they're happening and if they're related to something that you're eating, this would be the list of foods that I would start with. I do not show you this list to tell you that you should stop doing all these things or stop eating all these things necessarily. It's more just that it's a good starting place for ideally for you to be able to sit down with a dietitian, with someone on your care team who can review this with you and possibly see if there's a pattern there. But this is usually the place that we start and the most common triggers of digestive symptoms. And it can even be the case that, I ate it yesterday and I was fine, but today it gave me trouble. And why that might be, there might be so many different factors that can make our reaction to foods different from one day to the next. And so for a lot of people, it can be really beneficial to keep a very simple food diary, maybe for one day, maybe for 2 or 3 days. You can get a lot of information and insight about your own patterns of eating and what might be triggering or making certain symptoms or side effects worse for you. And the foods that I'm sharing on this slide, these are all good sources of soluble fiber, which is one kind of fiber that you find in our food. And I share this with you because just taking one of the common digestive issues that people will have, diarrhea is something that's very common, and there can be a lot of things we can do diet-wise to help manage that and help minimize and avoid making it worse. And if any of that is, if you relate to any of that or you're experiencing diarrhea during any part of your treatment or after a surgery, this can be a list of foods that may actually agree with you better and can help to manage the situation, in addition to other medications, of course, that we give you to help manage it. And even if you've been told to follow a low fiber diet, even if you've understood that you tend to tolerate the higher fiber foods, even if you do not tolerate those high fiber foods well, sometimes some of the foods on this list you might actually still tolerate okay, and they can be beneficial or therapeutic for you. I did want to share just a couple quick resources. These are some of my favorite places to send folks when you're looking for menus and meal plans and recipes. The American Institute for Cancer Research is a great resource for all kinds of nutrition information, but they have some very good recipes and sample menus. The Yale Cancer Center, of course, we have a lot of good nutrition videos and some how-to recipes. The 2 books at the bottom, those are actually printed cookbooks that you can find and that we highly recommend. And then another website is cookforyourlife.org. Again, great resource for recipes and menus. And the American Institute for Cancer Research there is on the right again. So I'll leave you with just a couple quick thoughts in addition. So you're going to hear a lot more about prehab in the next session after me, but prehabilitation or prehab really refers to taking intentional steps when it comes to your nutrition, your physical activity, your overall condition to give you a good foundation to walk into the next cycle of treatment or a major surgery. And so some is better than none when it comes to prehab or prehabilitation. But the more you can do, usually the better. And if you answer yes to any of these questions that I'm sharing on this slide, then you may actually benefit from a more intensive period of prehab, working primarily with nutrition and physical therapy services to really make the most of what you're doing on a daily basis and help prepare you for that next step, which again might be a major surgery or a particular course of treatment. And then on the other side, maybe following a major surgery, we look at, we think about recovery and rehabilitation or rehab. And one of the most common questions I get, is how much protein do I actually need to be eating? And so while there can be a lot of customization to this number, I'll give you this quick answer, which is really to take your current weight and the number of pounds, multiply it by that number, 0.55, and that's usually the minimum goal that you should have. You may benefit from getting even more protein than that on a regular basis. But if you're recovering from major surgery or recovering from a course of treatment, that's probably the minimum grams of protein to be eating in a day. So there's so much more we could cover, but that's a good start. And I'll stop there. Thank you.
Thanks, Lora. And I think, the field of nutrition is evolving. I'm sure many of you, once you get a diagnosis of cancer, will hear from colleagues or friends, oh, try turmeric, try this supplement, take probiotics. There is, an integrative medicine website, which actually goes through all of the nutritional supplements with their pros and cons as it relates to cancer patients. We are very supportive of integrative cancer care, and Lora will work with you in terms of thinking about which supplements are good, which supplements are not good. But I think, unfortunately, we don't have enough research in many of them. There's always some research, but there may be contradictory research. And so it's difficult to clearly work on that. But I think, the hope is that in the next few years, we'll have much better science regarding both the microbiome as well as nutritional supplements. But I think for now, simple rules of thumb, antioxidants, fruits, I think, Lora, would you agree are generally good things from an anti-cancer standpoint?
Yeah, absolutely.
Wonderful. Our next speaker is Scott Capozza. Scott is a physical therapist and actually has a particular interest in cancer prehabilitation, speaks in several forums, including nationally, on this topic. And we're fortunate to have him as part of our program. So he's going to speak a little bit about prehabilitation before major surgery or chemotherapy.
Great, thank you for that introduction, Dr. Turaga. So you may be wondering, why would I see a physical therapist or a physiotherapist, depending on where you're calling from around the world? Why would you see a PT before you would potentially have surgery? Normally, you would see a PT after you have surgery. But as Lora was just alluding to, being able to see PT prior to surgery or starting the next course of your cancer treatment can help physically prepare you to get ready for those next steps of whatever is coming next for your treatment. And I would argue that it's going to help mentally to prepare you. During a time when you feel that you don't have a lot of control over what's going on in your life right now, I think there are two things that you could have control over. And that's how you eat, what Lora just was talking about, and how you move your body. And there is emerging research that does show that being able to do prehab prior to abdominal surgery, to cancer surgery, does improve post-surgical outcomes. So again, when we're talking about what is prehab, I'm taking a look at where the person is starting from. What are the different lifestyles that person is living right now? And I like to also understand, what's your exercise history? Did you used to work out in the past prior to your diagnosis? Did you try to work out during your diagnosis? And again, prehab can include the exercise component, the nutritional component, and the psychosocial implications as well. But again, my role as a physical therapist to try to increase your functional capacity by really ramping up your physical activity, both your strength and your cardiovascular exercise, to get your body ready for whatever is coming next down the line. So the question is, how do you do prehab? How do you do PT in the prehab setting? Well, to work with a physical therapist or physiotherapist, the physiotherapist would be able to design a structured, individualized program for that person. So just like Lora gets the question, what's the best diet for me? People will ask me, what's the best exercise to do? And there may be some general exercises that I feel everybody can do, but I want to be able to personalize it and find out where are your strengths and where are your weaknesses. And obviously, I want to be working on your weaknesses and what we can do to help get you stronger. If you can do this in a supervised situation, I think it's a little bit safer, and that could be supervised in person. It could be over telehealth as well. I always enjoy doing telehealth because it forces me to work out too. If I have to get the resistance bands out and demonstrate an exercise, then it's a sneaky way for me to get my own workout in. So I kind of like doing telehealth visits. But I would say that, yes, I'm going to be focusing on core strengthening, especially for any kind of abdominal cancer surgery. And when I talk about the core, I'm not just talking about your abs. I'm not just thinking about the six packs. I'm thinking about everything from your shoulders to your hips. Because if you don't have a strong foundation, then it's so much harder to roll over in bed, get out of a chair, be able to walk to the bathroom, be able to walk around your own house. And so the biggest challenges that I see is, how do I do this? How do I implement prehab specifically and exercise globally into my daily life? And this is where I really need to get to know the person. This is where I'm really listening to you, the patient. And we're going to talk about goal setting. What's important to you? Obviously, yes, first and foremost, we got to deal with the cancer. We got to treat the cancer. We need to get you healthy. But beyond that, what are your goals? What do you want to get back to? Do you want to run a 5K? Do you want to hike the Grand Canyon? They're your goals. And so it's my job to help you realize those goals. I think the second thing to think about is time. There are only 24 hours in a day, and hopefully you're getting 7 to 8 hours of sleep. So where do you find the time to exercise? People will ask me, what is the best time to exercise? And I will always tell them, whatever is a good time for you. You might be a morning person. You might be that person who doesn't start their workday until 9 a.m. So maybe you have a little time in the morning to be able to go for a walk or maybe get on your indoor bike before you go to work. You might be a better person to exercise during your lunch break. Or you might be one of those people who is a night owl and you prefer working out later in the day. Honestly, wherever you can find time, wherever you can create these pockets of time in your schedule, I tell people all the time that if you have little kids and you bring them to the soccer field, or Dr. Turaga, I know you go to the cricket fields. You drop your child off at practice, you can walk laps around the field. And that's a sneaky way to get in a 30-minute walk. I would also say that to help somebody start an exercise program and adhere to an exercise program, you want to recruit a friend. You want to be able to recruit a coworker or your neighbor or a family member, because if you agree to meet at the trailhead at 8 a.m. and if you don't show up by 8:10, you are going to get an angry text from your friend saying, I'm here in the cold with my mittens and my hat on, where are you? So doing the buddy system helps with adherence to an exercise program. And I would also say that every day is a new day. So if a day goes by that is, you have a busy day at work, you have a busy day with the kids, and you don't get an opportunity to get something in, that's okay, because tomorrow is a new day and it's a new opportunity. And maybe before you go to bed, you can look at your schedule and say, when can I potentially get some exercise in for tomorrow? And so when people ask me, well, what's the evidence? I'm so grateful that I have these American College of Sports Medicine exercise guidelines that came out in 2019. And these are the guidelines that I follow when I'm talking to people about not just the amount of exercise, but the intensity of the exercise. And we can even break it down even more to say, if you're really feeling tired, if you're really feeling this cancer-related fatigue, that's going to be one exercise prescription, so to speak. But if you're experiencing increased anxiety and depression, if you have this increased fear of recurrence because of your cancer, I can prescribe exercise, and that's a different dose. It's a different amount of exercise based on how you're presenting. And I think that that's really powerful. It's a very powerful tool that I have that I can share with my patients. And after surgery or after treatment, I want to see you again. I will message Dr. Turaga and say, when can I see this person again? When can you clear them to come back and see me? And I think that's one of the other beauties of prehab is that we can create this relationship early on, and I can follow you, or you can follow your physiotherapist through all of your treatments from prehab into active treatment and after treatment. Because ultimately, my goal, especially if I've seen you in prehab, is I want to be able to help bring you back, to return you to your baseline function. And in closing, I think somebody who was very successful in his life had a great quote in saying that the best way to get started is to quit talking about it and to begin doing. And so I think we should all think about, again, tomorrow is a new day. What can we do to integrate a little bit more exercise, a little bit more movement into our days? Thank you.
Wonderful. Thank you, Scott. That was incredible. And I have to say, I loved your example of 30-minute walking when you're watching the kids. I know it's a little signal or a hint, but I certainly will take that up. It's wonderful. If any of you have any questions, please feel free to put it in the chat. The webinar session doesn't allow for a very easy dynamic conversation, but we're happy to answer any questions that you have. And I think our last speaker for this session is one of our surgery residents, Dr. Elizabeth Godfrey, who has actually been working with the consortium work on appendix cancer and has done incredible work that hopefully you'll see published in a year and then will be disseminated through ACPMP. But looking at pathology and looking at surgery and chemotherapy. But I think in doing all of this, Dr. Godfrey has also done some very interesting work in trying to think about how can we make decisions and how can we as providers make it easy for patients to make decisions when they're faced with the choice of undergoing cytoreductive surgery with or without HIPEC. And so she's going to speak a little bit about her proposed research, which is called DECISIVE.
Good afternoon, everyone. I want to start by thanking you all for sticking around to listen to me, to give me a little bit of your afternoon. One of the things that started to come up as something that patients told us was important to them was that these decisions that people are making when they're talking about cytoreduction feel very big and sometimes heavy to make. And your perspectives and experiences have told us that we as a whole field can do better about supporting you through that. And there's techniques called decision age, which I'm going to talk a little bit about as we proceed through the next 10 minutes, that I think could be a real opportunity for us to work together to make something that makes your lives easier and makes the lives of people in the future affected by this easier as well. So you don't need me to tell you that you're a very special population with unique needs. You have a lot of unique considerations. You're making big decisions while you're balancing a lot of other obligations and responsibilities. So that's part of the reason why we want to embark on this initiative to smooth out the process for you, to help you make it relevant to you. And all of our amazing team have talked about so many of these considerations that you're facing, that they're helping you navigate to make these decisions smoother. Even in a group like ours with so many amazing people to help you, it's still a challenge and there's still ways to make it better. And even more so, there are groups all around the country who maybe don't have so much star power to rely on, so many ways to support you, that would benefit even more from techniques and tools that could help you bridge the gap and make your decision-making process easier. And as a side note, Terri just shared a link in the chat for you to respond if anything resonates with you. If you want to help with this effort, provide input, so you can follow that link at any time and give us any responses. So in medicine in general, when we see a human experience that's challenging, we go back to science. We're scientists as well as doctors. We study it so we can do something about it. And decision-making is a very human experience. It is something that can be difficult to reduce to a scientific question, to numbers and tests. But we do know that science can help us make decisions better, both as doctors and as people who are helping patients make decisions. There's a lot of what's called decision science that revolves around other conditions that are more common. There's a lot of decision science applied to cancer specifically, but also to fields like transplant surgery, breast cancer surgery, surgery and other options for people with heart failure, people thinking about bariatric surgery. Appendix cancer, as we've talked about a lot today over the course of this day, has a lot more information out there, a lot more researchers doing great work than it used to. But there's still relatively few studies that are exploring the patient perspectives, the decision-making experiences, systematically representing the experience that all of you are having as patients and family members in a way that we can learn from and use to build tools for you. In fact, only one of the studies that's out there in appendix cancer asked if patients felt like they were supported enough in their decision-making, and none explore the identification of what's called patient-reported outcomes, or finding out from patients with appendix cancer exactly what parts of their therapy matter the most to them. So for the most part, we're dependent on our experiences and our individual stories that patients have told us, which for a team like this is a wealth of knowledge. But for teams that have had less experience or are newer to it, or are smaller groups, it leaves patients without the opportunity to get as much support and information as with teams like us. Unsurprisingly, given all the other things that we don't have good information about, things like decision aids that exist for a lot of other kinds of cancer don't exist for appendix cancer. And so we see an opportunity to create one, to build one with your help, to help you and the people that come after you make more confident decisions that meet your needs about things like timing, extent of surgery, what surgical options you want to be thinking about, things like that. So I keep saying the word decision aids. So what do I mean by that? Decision aids are a really broad category of clinical tools. It can be anything. It can be an app, it can be a pamphlet or a brochure. A new patient package is a type of decision aid. It can be a website, but whatever it is, it has to do three important things. First, it has to make the choice that you're facing and your options explicit and clear to you. It has to present the data that matters the most to you. Then finally, it has to relate the data that it's giving you and the choices that you're being presented with to the values that you're telling us, or you're telling the decision aid you consider most important. So that is, it highlights what the important information for you to know to make a decision is. And I want to add that there's a lot of knowledge out there, a lot of science about decision aids in other fields that shows they work really well. A major study of over 100 decision aids, a variety of types, demonstrated that they do the following 4 things for patients. They increase knowledge about treatment options and risks and benefits. They decrease what's called decisional conflict, which is a sense of unease or discomfort with a decision, even for people who don't regret the part of their journey they've been on so far. Sometimes there's a sense of unease when you don't feel well prepared for your decision. It helps make decision-making with your clinical team more shared and transparent, and that's very helpful as well for your caregivers, your support system, so that everyone feels like they're in the same loop and on the same page. And finally, they've been shown to increase the percentage of decision points that you traverse that match the values that you say are most important to you. I'm going to show you some examples of how these can look, and I want you to be thinking as I proceed through them about what kinds of things you think would be helpful. These show 2 different approaches to how decision aids are constructed, but ultimately a decision aid is all about what works best for the patients you're making a decision aid for. The first one is called Choosing a Breast Surgery for Breast Cancer. This one was designed by one of my mentors, Dr. Rachel Greenup, who's an amazing breast surgeon and clinical scientist who studies decision-making in patients experiencing cancer. And one of the decision aids she's helped create is about whether you choose a mastectomy or a lumpectomy for those people who are familiar with breast cancer surgery. So brief trigger warning, there will be a sort of cartoon stylized image of a lumpectomy and a mastectomy. It's nothing graphic. I just want you to be aware before I go to the next slide. This is an image from her decision aid. It starts with an education module, so that helps people get up to speed to remind themselves of all the information they've been learning in their cancer journey. And then the specific picture shown at the right shows profile 1 and profile 2. Profiles are pairs of possible outcomes. So it calculates what your risk is of specific things that might be important to you, like an out-of-pocket payment for your healthcare or your risk of recurrence, things like that for a decision aid of this type. And it asks you to pick between pairs. So it says, if I choose this surgery, this is what the risk profile looks like, what the possible outcomes are. If I choose this surgery, this is what it looks like. And it plugs that all into a black box of computer calculations that's able to calculate, once you've checked enough of these boxes, what priorities matter the most to you. And some people already know what priorities matter the most to them, but for others, it can be a challenge to think, well, gee, is it more important that I get out of the hospital faster, get back to my family, or is this other characteristic of my care more important? So this helps people get a good handle on that. A limitation of this approach is that because you have to pick through all of these profiles, it can make you spend extra time thinking about more things that are taking up your time. So figuring out how to approach a problem like this with an aid like this without taking up too much of your time and energy is one that we don't have a perfect answer to yet. A second example is more of a passive tool. It is about a tool that you can take home for your reference, your exploration at your own pace. It's a little bit more like most of the written materials that programs that do have decision aid type support provide. It's called Deciding Together, and it explores what's called an LVAD. So that is a supplemental heart pump for people who have heart failure. And the components of this particular decision aid show some basic information, again, getting you up to speed, reminding you of what you've already been talking about, and then describes recovery. It shares patient stories. It distills data down into a visual way, and it also provides resources for caregivers and a guide for consultation. So this is a brief visualization of how it presents data and how it presents risk. In this case, it shows, the number of people per 10 might experience something like this. So it helps data be more understandable. And I'll take a beat to step back. I've alluded to the resources that already exist for patients facing cytoreduction. You all know that this is such a specialized field, and we've all had the benefit of having this day of talking to people who all understand that and understand more about this condition than most hospitals, most physicians do. And our patient advocacy groups are some of our best supporters in getting you the information you need to make decisions. And programs like ours provide a lot of our own resources as well, but there's not much that's available on a national or an international level that's validated by science, that's supported by the synthesis of all the stories you tell us, that allow us as well as all of our colleagues across the country to support you best. Our plan has 3 main steps. We need to characterize your experiences with decision making. We need to define what matters the most to you, and we'll use that to make this decision support tool. The steps that involve you are interviewing people like you. So that's going to be the first part of our initiative to create this decision aid. And we will distill all the key outcomes, values, and experiences from those interviews, and then come back to work with our patient advocates like you and some of your fellow patients and caregivers and support system, and figure out how best to elicit your values, provide information, and make a tool that works for you. And then we'll need to test that tool, send it out to people who've had this experience and see what they think. So I'll sum up. We need you for all of those reasons. Feel free to follow the link. There's a QR code that I'm going to show you if you want to scan it, if that works better for you. If you're interested in helping us, we would love to have your support, because you're the reason we do this, and your perspective is really the one that matters. So thank you for your time.
Well, thanks, Elizabeth. That was wonderful. I know we've reached sort of the end of the time for our regional session. If any of you have had questions that you weren't able to ask, or you want further clarifications, feel free to reach us at our emails that are here. Greg is our program manager. Greg, is your video on? Let me see. So Greg is a wonderful resource who'll be able to happily steer any of the questions that you have. And certainly that's my email as well. So Jim, thank you very much again for having us be part of this wonderful symposium again. And it's just delightful to be part of this. Now, is this our 4th year or 5th year? Or even longer, maybe, doing this.
I
So
think it's our 5th, but I want to thank you and your entire team for, once again, your outstanding support of the patient and physician community, and doing really an outstanding job on today's presentation. So thank you very much, team.
Thank you.
see you.
Okay. So long.
Mhm.